Welcome and thank you for joining us for tonight's webinar entitled Hearing Technology Outcomes Matter, Speech Perception Testing. Our presenter tonight is Dr. Alejandra Ullauri, the Director of Chicago HearCare. My name is Alyssa Parazzini, and I'm a National Walk for Hearing Manager here at the Hearing Loss Association of America, also known as HLAA. The mission of HLAA is to open the world of communication to people with hearing loss by providing information, education, support, and advocacy. HLAA provides people with hearing loss the tools for self-help, educates and advocates for the needs of people who have hearing loss, and promotes the understanding of the nature, causes, complications, and ways to address hearing loss. We offer educational information on many aspects of hearing loss, from technological and medical advances to coping strategies, resources for parents and children with hearing loss, hearing assistive technology, and more. HLAA provides a wide range of local and national programs and events, such as the Walk for Hearing. We also have a nationwide network of chapters around the country that offer peer support, education, and advocacy in local communities. Please see our website, hearingloss.org, for resources on hearing loss and information on HLAA events, especially the Walk for Hearing schedule and local chapter listing. Before we begin, I'd like to thank our CART provider for this evening, Whitney Riley. Thank you, Whitney, for providing captioning services. Also, if you have any questions during the presentation, please click Q&A, the button at the bottom of your Zoom screen. This will allow you to type a question that we'll be able to address at the end of Dr. Ullauri's presentation. We are joined tonight by Dr. Alejandra Ullauri, who is the Director of Chicago HearCare, a private practice focusing on hearing solutions based on patients' outcomes. Dr. Ullauri is an audiologist with extensive experience in the diagnosis and management of hearing disorders in the pediatric and adult population. And she is certified by the American Board of Audiology and Cochlear Implants. She serves on the board of directors for both Illinois Hands and Voices, an organization which offers support to parents and families of children recently diagnosed with hearing loss, and Child's Voice, a school offering educational services to children with hearing loss while focusing on listening and spoken language. Thank you for joining us, Dr. Ullauri. I'll go ahead and turn it over to you. Please begin when you are ready.
Thank you. Good evening, everybody. Thank you so much for joining us tonight. My name is Alejandra. I'm an audiologist. I've been practicing audiology for over 15 years. I'm based in Chicago, and I'm certified by the American Board of Audiology in Cochlear Implants. I also want to introduce Rebecca Wells. Rebecca is a graduate student at Northwestern University, and Rebecca and I put this presentation together for you tonight. So basically, I want to give you an overview of what we're going to talk about tonight. Basically, we're going to be concentrating on hearing technology outcomes. If you're joining us tonight, it's because maybe you or a loved one are considering some type of hearing device, whether that's a hearing aid, maybe you're considering a cochlear implant, or maybe you already wear hearing devices and you are wondering about what the expectation should be. So welcome, you're in the right place. I'm passionate about this topic, and I want to start with this quote from Dr. Jorgensen. I happen to know Lindsay and the amazing research she conducts. I got this quote from one of her recent articles, and she says that contemporary hearing rehabilitation of adults with acquired hearing loss is patient-centered and outcome-driven. And that's the main topic, that's the main reason why you're joining us today. And that's the reason why we've worked on this presentation, is because we want to talk about the results after the intervention. So if you have a hearing loss, you know this better than me, that hearing is not enough if you cannot understand what people are saying. So outcomes matter. Outcomes matter to patients and they matter to clinicians, because outcomes are the way we validate our work. So in order to talk about hearing technology outcomes, I want to give you a quick overview of what the hearing rehabilitation process looks like. So basically, we want to concentrate on 3 areas. The first one is the diagnosis process. So we want to get an accurate diagnosis. We want to know exactly what the problem is. That accurate diagnosis is going to lead us to an intervention plan, and hopefully that intervention should lead us to good outcomes. And that's exactly what we're going to talk about tonight. So this is just to give you a quick summary of what the diagnosis process looks like. And if there is one thing that I'd like you to take with you from this slide, is that the audiogram is just a little part of the comprehensive hearing assessment. So many of you, that if you have been recently diagnosed with a hearing loss, or if you're already wearing hearing devices, you're probably familiar with the audiogram. But just know that the audiogram is only part of the comprehensive hearing assessment. The audiogram is only a test of hearing sensitivity. So based on the audiogram, we can know what type of hearing loss a patient might have, what's the degree of the hearing loss, how severe the hearing loss is. However, we don't know what that means to our patient. We don't know how that patient performs outside in the real world. We cannot predict outcomes from an audiogram either. So just know that the audiogram, it's only a part of the diagnosis process. So when a patient comes to have a hearing assessment, and we determine the type of hearing loss, we determine the severity of the hearing loss, we also can determine where the problem lies. Is it a problem in the middle ear? Is it in the inner ear? If it's a problem in the inner ear, it's probably irreversible. At this point, we're gonna decide if we need to refer this patient for further testing. Do we need to initiate a medical referral? We work closely with ear, nose, and throat physicians. Or do we think that this patient is a good candidate for hearing devices such as hearing aids? So once we have the assessment, the majority of sensory neural hearing losses will benefit from hearing aids. Usually hearing aids is the first step because it's a non-invasive approach. So when we've decided that a patient could be a good candidate for hearing aids, we're gonna base our intervention, we're gonna base our recommendations on an accurate diagnosis, right? That's the first step. And now we're gonna select the hearing device that is best suited for our patient. So here are the good news. We live in a good time. Technology, we've come a long way when it comes to technology. Hearing devices, the sound quality is so much better than it used to be. They're more discreet. And also, I mean, we have so many options when it comes to connectivity and managing your hearing devices from your cell phone, maybe streaming music and so on. So we've come a long way and there are so many options out there. So once we make that selection, so basically during the selection process, us, the clinicians, are gonna choose options and we're gonna explain the options that we recommend to you, and we're gonna help you make that, that decision. So once we decide on the hearing devices, we fit those hearing devices, and then we verify the fitting. So thank goodness we now have technology and equipment to actually test what these hearing aids do. So we put a little probe inside your ear and we make sure that the hearing aid is doing what it's supposed to be doing inside your ear. So the intervention process also goes along with counseling. We want to make sure that our patients know about communication strategies, that family members are aware of these communication strategies, what to do at home. We also want to make sure that you know how to manage your hearing aids, how to put them in properly, how to care for them. We want to know that you can control your hearing aid using the different apps, and that you know how to use the technology that is available to you. And then after the intervention, this is my favorite part. We need to measure what's the outcome. What are the results? Basically, this is the way we validate our work. So the outcomes are very important to patients, but they're equally important to us clinicians. So we're gonna validate the intervention. Basically, I want to make sure when I see a patient that comes for testing, I want to make sure that the recommendations I made and the hearing devices I programmed for this patient actually brought benefit to this patient. So there are different tools we have to do that. So sometimes we use questionnaires, and those are quality of life, hearing benefit questionnaires, but we also can do some testing, and we call that functional hearing measurement. So basically, this is what you do with what you hear. Remember what we talked at the very beginning. It's not about hearing. It's not about hearing that people are talking. It's about understanding what they're saying. It's about being able to sustain a conversation in a meeting, in a restaurant, in a party. So at the end of the day, we want to make sure that the work we put in works. So this leads me to speech perception testing. And I'm going to explain what the test is, how we conduct this test, the results we get from this test. And then I want to walk you through some cases just to show you what the results look like and how those results are so important to patients and to clinicians like me. How we use that information to actually continue to improve our hearing services. So speech perception testing usually it's always conducted inside a sound booth. So in this picture, you can see that our patient is facing the speaker. He also has a speaker behind him that you cannot see in the picture. But I want you to pay attention that he's wearing hearing devices. Remember that we are measuring outcomes. So I want to know how well you're doing with the hearing devices we recommended. So we're going to test this patient. So basically what we're going to do is the patient is going to listen to some words and sentences that are going to come out from the speaker in front of him. We're going to ask the patient to repeat those sentences back. So we encourage the patients to repeat as many words as they can. If they hear only one word out of the whole sentence, just repeat that one word. If you hear 2 words, just repeat 2 words. If you hear the full sentence, great, repeat the full sentence. If you cannot make out what the sentence was, just wait, the next one is coming. So after we do we usually start this test in quiet because we want to get an idea how well, if things are audible to our patients, can they understand what they hear? And if they do well in that condition, now we make it more challenging and we add noise. Why do we test patients in noise? Because we want to try to mimic what they go through outside in the real world. Remember that our patients are not living in sound booths. They live outside, and the reality is that we all live in a pretty noisy environment, in a pretty noisy world. So we want to make sure that we know how they're likely to do outside. However, we are also aware that no matter how well they do in our clinical tests in a clinical setting, the real world can be even more complex. So noise comes from all directions and at different intensities and so on. But for the purpose of clinical testing, we test our patients in quiet, and then we add noise just to give us an idea of what's going on once they walk out of the clinic. So after we do that, we get a percentage score. And this is the best part. So what does that mean to us? So basically, speech perception testing provides clinicians with a baseline. A baseline is where we're going to start from. So when a patient walks into our clinic and says, I wear hearing devices, but maybe I used to do well with my hearing aids, but recently I've been struggling more. The first thing I want to know is like, what does he mean by struggling more? I want to put some kind of score next to it, because struggling more, does it mean that you hear 90% of what's being said, or does it mean that you hear 20% of what's being said? And that's a big difference. So the baseline, so the first time we test this patient, we're gonna get what we call a baseline. This is pretty much where we start from. And then we're gonna test this patient after we make recommendations. Maybe we change technology, maybe we reprogram the hearing devices and so on. And then we're gonna be able to compare scores, and we're gonna be able to measure the improvement. Speech perception testing scores also allows us to measure the effectiveness between one type of hearing technology and another. So let's say that a patient is considering a Baja system or maybe a Bicross system. So these are two different kinds of hearing devices, and one requires a surgery. The other one is a non-invasive. The other one looks pretty much like a hearing aid. So we want to make sure that if we are going to recommend, a surgical approach, it's the right recommendation, that the patient actually does better with that device. So in this case, we can actually test the patient in the sound booth with one device versus the other device, and we can see the difference. We can measure the effectiveness of each one. We can also measure the effectiveness of different programming strategies or different programming formulas. So for those of you listening tonight, and for those of you that wear hearing devices, either hearing aids, cochlear implants, your audiologist is actually using your audiologist chose a strategy to program your cochlear implant. Your audiologist chose a formula to program your hearing aid. So we all have different clinical preference in terms of, I like this strategy better than this other strategy. But for instance, with our patients, I usually try this prescription formula for hearing aids. But I also know that not everybody does well with that prescription formula. So I may want to try something different if I see that my patient is not making progress. So by doing some testing, speech perception testing, I can actually measure the difference. I can actually measure how well my patient understands the speech with one versus the other. Speech perception testing is a key test when we're assessing patients for cochlear implantation. And the main thing, another key point is that speech perception testing is a great tool to measure progress over time and monitor progress. And here is another key piece of information that if you forget everything I've said tonight, this is important. If you wear hearing devices and you are very successful right now and you're doing great, you just keep, live your life, go on with your activities, keep in touch with your audiologist. Just because hearing deterioration can happen, it happens slowly. So many people don't notice it until it's really noticeable and they've been struggling for some time. But if you keep up the appointments and you keep in touch with your audiologist, we can monitor your scores over time, and we'll be able to catch any changes in your hearing or any changes in your listening performance at the right time, instead of catching it when you've been struggling for months, years before that. So being able to measure progress over time and monitor patients over time it's very important it's very important so we can make sure that you're always hearing at your best. And in summary, speech perception testing measures the functional capacity of the hearing system. So with that, I'm gonna show you a few cases, and I want to walk you through what speech perception scores look like, how they might change, and what we do with the information that we get from this kind of test. So our first case is it's a bilateral hearing aid user. You have on the right the audiogram. For those of you that are not so familiar with the audiogram, red is right ear, blue is left ear. And this patient comes in. This patient has been wearing hearing devices since early childhood. This patient thinks that she's not doing so great with the hearing aids that she has, and she's wondering whether she should consider cochlear implants. She's heard about cochlear implants, but she wants to know whether she should just change hearing aids because she knows that she's not doing so well. So she walks in, and the first thing we do, we make sure that her hearing aids are working, and we do some testing. So this patient is sitting in the booth. She's wearing her hearing aids. HA stands for hearing aid. And we ask her to repeat some sentences. First, we do that in quiet, and she scores 55%. To me, that's a red flag. If you're scoring 55% in a quiet environment, it means that in a quiet environment, in the best situation, you can hear half of what people is saying. In background noise, it's only gonna get worse. And this is a young patient that goes to work meetings, socializes with friends, and so on. When we do the same test in noise, the score drops to 45%, because of course, the moment you add noise, things get a lot worse. So then we have devices in our clinic that we can program that moment and demo a different device. So we change hearing aids, we reprogram those hearing aids, and then we retest the patient. Now the patient scores 86%. So the patient pretty much improved 30% in quiet and about 25% in noise. To me, the way I read this information is like, this is great, I'm on the right track. That is the right recommendation. So if we change hearing aids, this patient is going to do better. However, I can also see that she's understanding 70% in background noise. So that also tells me I need to do more programming. I need to concentrate on trying to improve that score in background noise, because maybe I need to create a noise program. Maybe I need to make the noise reduction features in the hearing aid be more aggressive. I need to do something so I can improve her score in background noise. So our next case, this is a patient that has a hearing loss since childhood, very irregular hearing aid use, very, very poor speech understanding in the bad ear, which is the left ear. Because she's got poor speech understanding in that ear, fitting a hearing aid might not be the best option. So we tried a bicross hearing aid. A bicross hearing aid means that we're gonna put a hearing aid in the right ear where she's got a mild borderline hearing loss, and we're gonna put a microphone that looks like a hearing aid, but it's only a microphone that sits in the left ear. So when she's at a restaurant, the person who's sitting on her left can speak to her. The microphone will pick up the signal, will send it over to the right ear, and she'll hear with the right ear. So before we recommend anything, we want to make sure that this is the right thing to do. So we test this patient, and instead of having her face the speaker, we actually have the speakers at 90 degrees. So one speaker on her right side, other speaker is on the left side. To make things very challenging for her, we're gonna put the speech in the left ear, which is her ear with the microphone, because that's her bad ear. And we're gonna put the noise in her right ear. This patient scores 97% in background noise. So these are good results. This is another patient that was, we were thinking whether it was worth discussing a BAHA system. This patient was a little borderline for BAHA criteria. BAHA is a bone-anchored hearing aid. It's usually implanted in the back of your ear on the bone. I just wanted to get an idea if this was an option worth talking about. So we did some testing, and again, we have a BAHA in the clinic. We have bicross hearing aids, so we can demonstrate all these devices and get an idea of what seems to be better. So without hearing aids, just pure unaided condition, we ask this patient to repeat sentences, and we put background noise. And this patient can only understand 30% of what was being said. Then we put a BAHA with something that looks like a soft band in the left side, and we do the same testing. And he scores 55%. Then we do the same thing, but now we do it with the bicross system, which I just talked to you about, a hearing aid in one side, a microphone on the other side. The patient scores 94% in background noise. So in this situation, I feel confident that this is a good recommendation, that the patient seems to be doing, seems to have very good understanding, even in the presence of background noise. My next case, maybe this is my favorite slide. The reason why is because sometimes we think that speech perception testing is such a simple test. It's just asking patients to repeat sentences. We do it in quiet, sometimes we do it in noise. But the reality is that the scores that we obtain from these tests are so useful to us clinicians and to you patients, because it allows, these scores will allow us to make good recommendations, to make good decisions in terms of what would be the best device for you. So the other thing that I want you to pay attention in this slide is that we have a a patient with a hearing loss that is not that bad. I mean, she does have a significant hearing loss, but it's not a profound hearing loss. In the right ear, she's got a moderately severe hearing loss. In the left ear, a severe hearing loss. However, remember what we talked at the very beginning. We cannot predict, we don't know how much patients struggle hearing based on the audiogram. We have to do more testing to understand what's their speech understanding, to give us a better idea of how do they perform outside in the real world. So this patient in the unaided condition, so remember, unaided means no hearing devices. We make things audible to the patient by raising the intensity. We test this patient and she can only understand 24% in a word list. That's really loud. So then we give this patient hearing aids. This patient wore hearing aids for a while, so this didn't happen, in the same appointment. But the patient wore hearing aids. She was an experienced hearing aid user who was struggling, who decided to go for cochlear implant assessment. So the patient with the hearing aids, we test her in quiet. So she's in the booth, she's wearing her hearing aids, and we ask her to repeat the sentences. She scores 62%. Then we add noise, and of course that makes everything a lot worse. The score drops to 38%. And here it gets even more interesting. We do exactly the same thing, but one ear at a time. So right ear first, then left ear. And the patient scores 24% in the right ear, 62% in the left ear. This is great information for us. First of all, I'm confident to say that she's relying mainly on her left ear. Her right ear doesn't give her match. It could be, that seems to be the ear with the better hearing thresholds. However, even with the hearing aid, she only understands 24% in that ear. So basically, all her communication is relying on her left ear. So here, if there are no medical contraindications, maybe we want to consider implanting the right ear, because we'll give this patient an implant in the right ear, a hearing aid in the left ear, and she will become a bimodal user. So this is just to give you an idea how much information we get from speech perception testing and how much information we don't get from the audiogram on its own. So the next patient, thank you for continuing to be interested in this. We're nearly done. We have only 7 cases. So the next patient is a bimodal cochlear implant. Bimodal means that this patient wears a cochlear implant and a hearing aid. I just want to show you how we measure progress over time. So before she got the cochlear implant with her bilateral hearing aids, this patient scored 45% in quiet. Then the patient got a cochlear implant and she scored 74% in quiet 3 months after implantation. So this is great news. We're really happy. Patient is making great progress. 6 months later, she scores 88% in quiet. And here I want to pause because I want you to see, I want to highlight one thing. From 3 months after implantation, she went to, first of all, she went from 45 to 74% in 3 months, and from 74% to 84% from 3 to 6 months. So in the next 3 months period, she increased about 14%. what I want you to take out of this slide is that improvement with hearing devices takes time. Experience plays a significant role in this process. So this is not, you know, when people compare hearing aids to glasses, this is why we don't do that. Because it's not something that you put on and off you go, you do great. Experience plays a significant role. So when I see patients in our clinic and we demonstrate hearing aids and we say like, oh my God, you're already doing better and we can measure that and so on. I always tell them, if you like the quality of sound you're hearing now, it's only gonna get better. It's gonna get better because one, you're gonna gain experience with the devices, and also I'm gonna benefit from your experience. You're gonna come back to our clinic and you're gonna tell us everything. You're gonna relay your feedback to us. I wanna know everything that worked well with your hearing aids and everything that didn't work so well. I wanna know what's working well in the program and I need to keep, and what's working not so well and I need to change. So experience plays a significant role. As you gain experience, clinicians like me have the opportunity to make adjustments based on your feedback. And the combination of those two things make things better. It improves your speech discrimination, and that's how we see progress over time. So the next thing I want you to the next thing I want to highlight in this slide is that in quiet, she was doing great, 88%. But because she was already doing so great, we decided to make things a little worse, a little bit more challenging. So we introduced noise, and the score dropped to 57%. So this is crucial information for me because I need to make changes and I need to do something to improve that score. If she's understanding 57% in background noise, it's still not good enough. We still need to work on that. So she's gained a lot from 45% in quiet to 88%. So the cochlear implant is better than what she had before. However, there is still room for improvement. I mean, she's only 6 months post-implantation. We can do many things. The software we use with cochlear implants and hearing aids is really flexible, and there are many things that we can do. Next patient, this is a bimodal patient, same thing, cochlear implant plus hearing aid. This is a patient that walks in and says, I was doing well with my cochlear implant and my hearing aid, but lately not doing so well. I wonder if I need a cochlear implant programming, or maybe I need a new hearing aid, I don't know. So same thing, she comes in straight to the booth, we do some testing with her hearing aid and her cochlear implant. She scores 45% in noise. This is a patient that goes to group meetings, volunteers, social things, and so on. So in background noise, she's understanding less than half of what people say. So then we program a new hearing aid, we make changes to the CI, to the cochlear implant, and we retest her. And within one session, she goes from 45% to 70%. So this is great. However, 70% is still not super good. So that means, to me, what do I do with those scores? If I was able to bring this patient from 45% to 70% in one session, I'm super excited because that means that I'm on the right track. The recommendations I'm making are good recommendations. We should work on that. So then this patient gets the hearing aid. We program the hearing aid. We verify the fitting. Patient goes home, comes back and a month later, and we do some testing. Now, based on that 70% score, we created a noise program and made some adjustments. So she comes back a month later. Now she's scoring in her everyday program 79% when there is background noise. But if she changes to a noise program, her score goes up to 87%. So again, this is really good news. My last case is a patient who's legally blind, who recently went for bilateral cochlear implantation. I guess what I want to highlight here is same thing, how we monitor progress 3 months post second implant. So she had one cochlear implant, and then she went for a second cochlear implant. 3 months after, she can understand 74% in background noise. 6 months after, 84%. 9 months after, 96%. I can't tell you how happy I am with this case, because this is a patient that relies on hearing. Because she's legally blind, hearing is all she's got for when she's walking in the streets, when she cannot rely on lip reading, she cannot rely on sign language, she cannot rely, when she's out with friends in a social situation with background noise, all she's got is her ears. Same thing when she's out in traffic. So to have these type of results, of course, this is a lot of work, this is a lot of programming appointments, lots of feedback, but it's possible, and I wanted to show you how we can measure that, and also how we use those scores to make decisions. So before we open up for questions, I just have this little summary for tonight. A couple of things that I want to highlight. First of all, remember, if you are new to the process, try to see a doctor of audiology. Remember that, oops, sorry. Can I go back to my previous slide? Remember that an audiogram is only one piece of the comprehensive hearing assessment. We cannot predict outcomes from an audiogram. We don't know how well you're doing outside. So an audiogram is only a test of hearing sensitivity. And then if you get hearing devices, we can actually measure how well you do with your devices. If you are already wearing hearing devices and you're wondering what should I expect, we have tools, as clinicians, we have tools to measure outcomes after the intervention. This is very important to us as professionals, because this is how we validate our work. This is how we measure that the recommendations we made worked. So we can measure outcomes. We can also make new recommendations, because some people might do well now, but things might change in 5 years. In some cases, I mean, there are complex cases. So if I see a patient that we've been testing and retesting, and we don't seem to be able to increase their performance, and no matter what we do, we're still struggling with speech understanding, well, I'm able to see that despite doing everything and despite the patient gaining experience, we're not moving forward. So this is also a time for us to say, maybe I need to get the clinical specialist from the cochlear implant manufacturer involved. These are audiologists that have extensive, very specific training in the devices they work with. So they could be great help if they come and work with us in the clinic, and we can say, we've tried these. Do you have any other suggestions? Am I missing anything? This is also a great time to maybe call a colleague, and we all have complex cases, and we all have patients that might struggle more than others. So speech perception testing allows us to see who's making progress, who's not making progress, what we need to change, and despite those changes, is this person still not improving as much as we were expecting. So basically, it's a call to action. And yeah, outcomes matter to you and to us as professionals. Thank you very much.
Thank you, Dr. Ullauri. We have a few questions that came in, which I'm happy to read to the group here. The first one is, how is this different or similar to the results of testing at the beginning of the LACE training system to improve speech comprehension? And LACE is spelled L-A-C-E.
Yep. That's a great question. So the LACE is an auditory training tool that many patients use at home. So this would not be, so this is not in a controlled setting as we will do in clinic. And I guess that will be the main difference.
We have a question from someone. I wear bilateral hearing aids, moderate to severe right ear, and mild moderate left ear. My audiologist did minimal speech discrimination testing, although I have speech discrimination issues and always have had this issue, using headphones and not speakers. I have to go back and be tested once again. Is it okay for me to ask to have more speech discrimination testing done with speakers instead of headphones?
Were the headphones used on top of the hearing devices or without hearing devices? Because if you're being tested with headphones, I'm assuming you're being tested in the unaided condition. So the next step is to test you in the aided condition, which means that you will have your hearing devices on, and then the speech has to come from the speakers.
We have a question from Tony in Michigan. He says, I'm an experienced hearing aid user. I can't tell you the last time an audiologist tested my hearing with the hearing aid in my ear. Is this normal for the audiologist to dismiss this test for long-time wearers of hearing aids?
What do you mean with, I'm not so sure if I understand the question. The patient was tested in the aided condition wearing hearing aids, or he's implying that he hasn't been tested in a while?
That's correct. So he is an experienced hearing aid user, and he said he can't remember the last time he was ever tested wearing his hearing aid in his ear for the test. Is it normal to be tested with the hearing aids in, or could there be a difference since he's a long time hearing aid?
Yeah, speech noise testing, speech perception testing before used to be done mostly by cochlear implant audiologists and cochlear implant centers, but now it's a more widely used tool. So I would say go back to your audiologist. If you haven't been back in a while, it's a great excuse. You should always keep in touch because your hearing might change, new technology might come out. So this is a great excuse to go back and be tested.
Tony has a follow-up question that I've heard about hidden hearing loss, where people pass audiologic testing but cannot understand speech and noise. Does this imply that these people have not been through the testing that you have just described?
No, I think we're talking about two different things. So hidden hearing loss would be some patients that might have outer hair cell damage, but it's not showing in the audiogram yet. So if we do autoacoustic emissions, we can actually test the outer hair cell function inside the inner ear. Those outer hair cells are like a natural amplifier for all of us. And they can be damaged because of noise exposure or ototoxicity, like ototoxic medications such as chemotherapy and so on. So some people that have been exposed to noise through, I don't know, playing in a band or going to concerts and not wearing hearing protection and something like that, they might start experiencing some hearing loss symptoms. But they come, and if we only do the audiogram, which is going back to the same point that the audiogram is just one piece of a comprehensive assessment. If we only do an audiogram, we will miss the damage already caused to the outer hair cells. But if we do autoacoustic emissions, we're going to be able to pick up that damage. Eventually, that problem is going to show in the audiogram. It just happens to show in another test at the beginning. So it's a completely different, so these patients are not wearing hearing devices at this point.
We have a question from Vicky from our Colorado Springs chapter. When you make adjustments, what exactly are you adjusting? The volume, frequency?
That's a great question, and we could be here all day. Great question. We can adjust so many things because now hearing aids, cochlear implants have so many different features, and we have as technology gets better, softwares are more flexible. There are more things that we can work on and that we can make changes to. So there are many things that we can change. I can decide if the microphones of the hearing aid are going to behave in one way or another. I can decide if the noise reduction systems are going to be much more aggressive in one situation versus another. I might decide to keep one patient only in an automatic program because this patient is doing great, doesn't need to be fiddling with programs. I might decide that another patient needs very specific programs because of very specific activities that this patient does. So lots of things can be changed and can be adjusted within the software that we have now.
We have time for one more question from Ken. I am 66 years old and retired. I had sudden single-sided hearing loss in my left ear several years ago. It is 100% and not correctable. My right hearing is normal. How do I select an audiologist that understands my situation and knows how to select the best solution?
So I want to say that doctors of audiology will understand your situation. There are many options right now for people that have sudden hearing loss, that have unilateral hearing loss. So basically you have one ear with normal hearing, one ear with a significant hearing loss that can no longer be aided. So a cochlear implant was recently approved by the FDA to be used in cases like yours. We've been using in the past the Baja system, and we've been using Bicross hearing aids. So it all depends. So this is, thank you for this question, because I think I forgot to make this point during the presentation. We're always gonna suggest a non-invasive approach first. So hearing aids tend to be that non-invasive approach because it doesn't require surgery. If patients don't do well with hearing aids or with the Bicross system, then we have great news. We have other options, and we have implantable solutions. But so there are a few things that you could benefit from. It's a matter of knowing. I guess the first approach will be the Bicross system, as that is non-invasive. Depending how well you do with that, maybe you would consider a Baja or a cochlear implant.
Thank you, Dr. Ullauri, for your time this evening and for the information you've shared. Tonight's webinar has been recorded and will be posted on our website. Please be sure to visit us at hearingloss.org for future webinars and information. And don't forget to check out walkforhearing.org to find a Walk for Hearing near you. Thank you again to Whitney for providing captions, and to everyone for joining us this evening. And Dr. Ullauri, is there an email? There were
Yes,
a few.
I think it's in the next slide if you want
Sure.
to. Yep,
Sure.
that's it. So that's my
There were a few remaining questions that if it's okay with you, if the individuals could write to you.
Absolutely.
To
I
ask.
will be more than happy to take a look at them.
All right.
Thank
Thank you
so much.
again.
Thank you.
Have a good evening.